I'm Bill Bro, and this is Kidney Cancer News for March 2013. Our broadcast this month focuses on a series of presentations by experts in the treatment of kidney cancer recorded at the European International Kidney Cancer Symposium. And we'll follow that with several items of interest to families dealing with kidney cancer, including one news item that deals with a trio of biomarkers that may be used to identify kidney cancer. Let's get started.
Thank you for inviting me for dealing with this subject, which is a difficult subject about local recurrence after nephrectomy. I will focus in this talk about local recurrence after radical nephrectomy and not after partial nephrectomy. What data we have? We have obviously limited data in the literature about local recurrence after radical nephrectomy. We have additionally no clear definition of what a local recurrence is, and we have no standard of care in this rare situation. What is the most admitted definition of local recurrence after radical nephrectomy? It's obviously an heterogeneous situation. The most common definition is ipsilateral recurrence in the renal fossa, ipsilateral adrenal gland recurrence, ipsilateral lymph node recurrence, with or without metastasis. And most series that we have today are coming from surgical series, and we do not have information about the natural history about this local recurrence when concomitant metastases are occurring. And here again, I will exclude from this talk partial recurrence after partial nephrectomy. What is the frequency? It's between 1.8 and 2.9%. You see here that these two series did not include a metastatic patient, but this series include a patient with concomitant distant metastasis. We have only limited series. This is one of the largest series, which included only 34 patients. Coming from a memorial group. You see here that 47% of patients did have metastases at the time of local recurrence diagnosis. Of 18 patients with no metastases, 11 patients were able to have complete surgical resection and 7 had non-surgical therapy. Of the 16 patients with synchronous metastases, 5 had surgery and 11 did not. Median follow-up was 16.9 months. Over 11 patients in group 1, local disease with no metastases, 3 remained with no evidence of disease, 3 were alive at the time of a paper with metastatic disease, and 5 died from disease. In other situations, 91% of the patients died from disease. And you see here that the only group that seems to have a real benefit from surgery is this group with local disease and no metastatic disease, with a median survival time of 71.4 months. This is the second largest series that we have today, 54 patients. By contrast to the previous series, all patients here were M0 patients with no distant metastases, and all patients were operated with surgical resection of a local recurrence. The definition here included local recurrence of a renal fossa, ipsilateral adrenal gland, or ipsilateral retroperitoneal lymph nodes. A perioperative systemic therapy was given in 69% of patients. Median recurrence-free survival time was 11 months, and median cancer survival time was 61 months. You see again here that when surgery is possible, in this group of very selected group of patients with no distant metastases, it seems that we are able to get good survival and good long-term survival. However, the authors here were able to identify some specific prognostic factors that could affect recurrent and risk of death from cancer. It was positive surgical margin after resection of local recurrence, recurrent, the size of a local tumor at the site of recurrence, sarcomatoid features within local recurrence, and also biological features. You see here survival curves according to the margin status, and the survival for patients with negative margin, again in this cohort of patients without distant metastases, was 61 months when margin were negative, as by contrast to 28 months in case of positive margins. And this is survival curves according to sarcomatoid status of a recurrent tumor. We designed in France multi-center studies for identify those patients with local recurrence following radical nephrectomy. We identified 63 patients from 10 urological centers. The sex ratio was as usual in renal cell carcinoma. We observed a predominant left tumor side. Median tumor size at diagnostic was 7.5 centimeters. At the time of nephrectomy, there was a great proportion, greater than usually in nephrectomy series, a great proportion of patients with end stage of 1 or 2, 20%. All patients were M0 at nephrectomy. It was an inclusion criteria of the study. There was only 8 laparoscopic nephrectomies in this series, but it's an historical series. In 25% of the cases, lymph node dissection was performed, and we observe here what was not observed in previous series, that there was an important cohort of patients with papillary type 2 tumor, 27% of the cases who recurred after radical nephrectomy. What was the presentation of these tumors at the time of recurrence? 70% of the patients did have symptoms in relation to their recurrence. 31% had synchronous metastases. More than 50% of the patients did have lymph node invasion at the time of recurrence. Median time between nephrectomy and recurrence was 12 months. And here again, you see that there is a predominance of recurrence in the renal fossa, 52%, but also in lymph nodes, in lymph node and renal fossa, and in adrenal gland. This heterogeneous situation is translated in an heterogeneous care. In 20% of the cases, surgery was followed by systemic treatment. In 6% of the cases, systemic treatment was given before surgery. In the most frequent situation was surgery alone in 36% of the cases. And finally, systemic treatment was given alone in 23% of the cases. In the most recent period, patients received targeted therapy, and overall 16 patients received targeted therapy in this study. There was one death in the postoperative period. Overall, 44.4% of the patients died of cancer at the end of follow-up. The mean follow-up for this study was 23 months. Median cancer-specific survival for M0 patient was 42 months. Median cancer-specific survival for M1 patients was 20 months. And median cancer-specific survival for those patients who were able to have surgery was 60 months. And when looking at prognostic factor, we identify only this factor with a positive or negative margin, where margins were positive in case of resection in M0 tumor. You see that the median survival time is 22 months, by contrast to 75 months when a complete resection is possible. Now we see alternative methods for treating this patient with local recurrence after nephrectomy. This is a very recent series of cryotherapy of this local recurrence. Cryotherapy not only in local recurrence, but also in some metastases. But I identify here 11 cases of recurrence in the nephrectomy bed that were performed by cryo, 8 cases of adrenal gland treatment, and 6 cases of para-aortic lymph nodes treated by cryo. A mean of 2.2 procedures per patient was performed in this series. Major complications appear to be minimal, with 2% of major complication and only 3% of recurrence, which seems a little bit surprising. But nevertheless, median overall survival was 2.7 years, with an estimated 5-year survival rate of 27%. Rapidly, 2 cases for illustrating the difficulty that we have in managing these patients with local recurrence following radical nephrectomy. This is a 62-year-old woman. She had a radical nephrectomy, a radical left laparoscopic nephrectomy 1 year ago for a PT2 clear cell format grade 3. 1 year later, she developed 2 recurrences in the renal fossa. This is 1 recurrence. This is another recurrence here, close to the renal vessels. We decided here, after discussion, to treat this patient with TKI. And you see here that after 2 cycles of sunitinib, we have a major progression of a tumor here, and here with an evasion of the pancreas. So maybe in this case, we have missed the time for surgery. Another case, this man had a past history of left radical nephrectomy. He developed later on a synchronous pulmonary metastasis and local recurrence in the renal fossa. You see here 2 lesions, 1 here and 1 here in the muscle. Certain treatment was started with a complete lung response, a stable disease in the renal fossa, and a poor tolerance for Sutent. So we decided to do a complete resection of these 2 lesions in the renal fossa. We had negative margin, but unfortunately, 5 months later, the patient had multiple pulmonary recurrence and probably also a pancreas recurrence. So here we can discuss the usefulness of surgery in this setting. In conclusion, local recurrence following radical nephrectomy is rare. In case of isolated local recurrence and absence of metastatic disease, complete surgical resection remains the best option for obtaining prolonged survival. The role of targeted therapy in this setting is still to be clarified. And in case of synchronous distant metastases, the benefit of surgery here is questionable, and maybe in the future there will be an increasing role for cryotherapy. Thank you.
This was quite a tricky topic, and I think the title would have deserved a question mark as well. And I like to, when we talk about the evidence we have about cytoreductive nephrectomy and the survival impact, I like to compare this to this proverbial elephant in the room. And this seems to be, in this case, checkered by a pattern that disguises our view. There is an evidence, but it is not as clear, as visible as we would like it to be. And if we look at the data that are out there, and basically nothing much has changed since this publication of the RAND panel in 2006, then we can clearly say that we had a level 1 evidence in the area of immunotherapy with 2 randomized phase 3 trials, the SWOG and the EORTC, that clearly showed that it would probably be appropriate to do a nephrectomy in combination with interferon alpha, leading to a survival benefit of about 6 months in the combined analysis. But in all other instances, it's probably uncertain. And this has been reintroduced by the fact that with targeted therapy, we saw for the first time responses in primary tumors. Now, what we do have in data, and that's what I would like to take you through in the next slides, is that obviously nobody would contest this. You have a large football in your abdomen and 3 or 4 small lung nodules. So if there is a disbalance between the volume in the primary tumor and the metastatic sites, then it is very clear, as Barbara Stefano has shown in a small retrospective series, albeit, but building on data that have been produced in the immunotherapy area, that the more tumor volume you remove, the better is your progression-free survival and very likely your survival. And this is indirectly reflected in another publication. It wasn't the topic of this publication to to give an indication on nephrectomy, that was a publication where these rare incidences of complete remissions were analyzed throughout France, where 64 patients were looked at, and their status after they stopped with tyrosine kinase inhibitors. But very interestingly, and that's what I saw in this publication, is that all of these patients had at some stage in their disease, admittedly a lot of them for curative intent before the onset of metastatic disease, removal of the bulk of the tumor. So in other words, without nephrectomy, you're unlikely to have a benefit of a complete remission. Now, what we will have to acknowledge is that most of our patients we see with primary metastatic disease are not the candidates I just portrayed. Most of these patients are the ones who will have 30 to 40% of the metastatic load left behind once a cytoreductive nephrectomy is performed. And the only thing we have here are retrospective series, and I don't want to go through all of them, but just mention the better ones. Tony Chieri and his colleagues have analyzed about 314 patients, and they went through the effort to look at the influence of the performance by analyzing the Karnofsky score. And interestingly, here the survival is 23 or almost 24 months as opposed to 14 months in case of those who had the kidney removed. But we should never forget that this is retrospective data. They're very likely biased. There's always a reason not to perform a nephrectomy, and maybe some of these patients had never been candidates surgically for performing a nephrectomy. Therefore, I tend to believe the data is more, not because I live in the Netherlands, but I know that in the Netherlands, very often cytoreductive nephrectomy is simply not offered from point of views of opinions like we all have. But in this population-based analysis, we could clearly show that the hazard of dying of this disease was reduced by 50% in those patients, adjusted for all factors we had, all prognostic factors, for those where a nephrectomy was performed as opposed to where it wasn't. But what makes us believe that we can change the outcome? I mean, I will never forget this sentence, I think Vogelsang was it, who published it in his editorial to the Flanagan trial, that what's the use of closing the barn door once the horse has bolted? So why should we remove a primary lesion? We would never do that in bladder cancer, for example. But we all know that the microenvironment is very important in renal cell carcinoma. There's abundant data out there, all in small series, and some of them based in laboratory animals. But we know that there are pro-angiogenic factors, immunosuppressive components, and actually the anaerobic glycolysis that sets in and leads to tumor cachexia, which I believe is very much the reason of the previous speaker has alluded to. But there's compelling evidence, and I think it has been talked about already this morning by Marco Gerlinger's paper. And I think this is a very important paper, not so much from the point of view that with taking biopsies you may find different tumor areas for translational research. But what it also means is that if you leave a primary tumor in situ, it could mean that through Darwinian speciation you develop more aggressive subtypes that eventually kill the host. And is that of importance? Would that be of importance? If you look at the survival data we have nowadays with the targeted agents, if you would leave a primary mass in situ, and admittedly most of the patients with primary metastatic disease are of intermediate risk score because they already have this single factor of time from diagnosis to treatment less than a year, and only few would have good risk. But you are talking about a survival time of maybe 2 to 3 years. And we do not know what that means if you leave the primary tumor in situ with regard to these translational aspects. But we can already guess what it means for the growth of the tumors. There are smaller series out there. There's one from the Cleveland Clinic where resist progression, so not just growth of the primary tumor, but really resist progression was noticed in 47% of these tumors. We saw that in phase 2 trials, but I think the best data out there are actually from a retrospective analysis of 168 tumors from the MD Anderson, where the observation period wasn't as long as 2 or 3 years, but where it was clearly shown that though most of these tumors would respond, you could see here that about in 5% of these patients, you will have to take for granted that tumors will grow, and some of them even excessively. So yes, you may argue it doesn't happen in a lot of cases. But what prevents us actually to acknowledge that there may be a survival benefit? And I think it is all about selection, and we've never been good at that. If you look at the data from the SWOG trial, for example, and though they had as a selection criteria good versus bad performance, but what we see clearly here is that after 4 months already 20% of those who underwent surgery or no surgery died. And this is quite dire. I mean, for performing major surgery in these patients, we should really try to exclude these patients before surgery. You may argue, well, this is of yesteryear and we are doing better nowadays, but if we look at this recently published series from Kutikov from community hospitals in the US, and it won't be much different in Europe, I'm sure, then they analyzed why, for example, the percentage of patients that would progress to undergo systemic therapy. And in about 1/3 of the patients, they wouldn't get the therapy they needed. Of course, there are different reasons for that. And if there's decision for surveillance because the patient is faring well or the patient refuses, this is all acceptable. But if you collectively look at those who had rapid disease progression after surgery or even perioperative death, then we're talking about 15% of patients who have no benefit of this intervention. And we need better selection criteria. And the MSKCC criteria are actually based on oncological principles, and as Chris Wood has already alluded to, we need better ones, and they've done a retrospective analysis and came up with surgical risk factors, which are published in Cancer by CULP. And I think the best way forward without a trial at the moment would be combining these MSKCC, the MD Anderson surgical risk factors together with pre-operative therapy and only performing surgery on those who at least do not progress at metastatic sites. And this is a retrospective analysis of 2 phase 2 trials of pre-surgical therapy, which we published together with Tom Powles in European Urology. And you can clearly see here, if patients with intermediate risk and no progression of diseases metastatic sites would undergo nephrectomy, then their median survival at this observation period had not even been reached. And in all other cases, and admittedly we included poor risk as well, but also intermediate risk who would progress at metastatic sites, their survival would be less than a year. And this doesn't mean that there would be a survival benefit, but it is very likely that only those patients who have a long-term survival would at least pluck the fruits of performing surgery. And without biomarkers, and we don't have them at the moment, I think the best way is, if you do have access to these trials, the CAMINA trial that investigates the role of surgery, or the EORTC CERTIME trial that investigates the sequence of surgery, would be the best, because in both trials a translational program is attached to that is really necessary to come to more conclusions in the future and know who are the patients we will really have to perform surgery on and who aren't. And with this, I would like to conclude and thank you for your attention.
Kidney cancer, renal cell carcinoma. I was diagnosed in 2009, February of 2009. I know my one oncologist, well, more or less all of them were a little skeptical if I'd even pull through everything. I mean, we even had one doctor tell me that I should just go on hospice.
So we knew that probably doing some research into some clinical studies and getting hooked up with a really good oncologist that dealt with kidney cancer and how to treat it would be our best chance at hope.
Mm-hmm.
When I met him first time after nephrectomy, he was in a very dramatic condition. Not only that, the tumor was intoxicated his body to the point that he developed swelling, he developed clotting problems. He was unable to move out of bed. And suddenly, within a few months after we started standard therapy with sunitinib and then vaccine, his whole situation improved to the normal quality of life. He was able to function normally, take care of his family. So it was an absolutely dramatic change from laying in dying to normal function.
Gave us hope. And I think both of us expressed a lot that my gosh, they're using your own immune system and injecting your own cells and trying to teach your own body how to fight this cancer. And I felt like, wow, we made we might actually have a shot.
That is perhaps what keeps me going as an oncologist, to see those dramatic changes between the person who is suffering from terrible disease to a patient who can live with that disease normally. And that also gives me a tremendous motivation in trying new form of therapies and proposing those therapies to my patients on a clinical trial basis.
I mean, just being able to sit here right now and do this. Being with my wife, my kids. I didn't think I'd be able to do this.
I think it was the best choice that we could make at the time, and
I'm glad I
obviously
did
the
it.
outcome has been good, and we have more time together as a family, and boy, that's priceless.
Join your friends from the Kidney Cancer Association for a day-long live chat on World Kidney Day. Ours is the world's first charity dedicated to the eradication of death and suffering from renal cancers, serving more than 70,000 people in 100 nations. Point your web browser to our Facebook fan page to chat live with other families concerned with kidney health. Make new friends and share your story with others. For patients with kidney tumors, a new study shows the health and economic advantages to removing just the tumor as opposed to the entire kidney. Robotic surgery, including the Da Vinci surgical system and Firefly fluorescence imaging that lights up kidney tumors, are among the latest techniques to make this possible. Research regarding vaccines has been of special interest for the treatment of renal cell carcinoma for more than 30 years. Stable disease lasting months was observed in 8 patients in a trial. Results suggest that VEGFR1 peptide vaccine is safe and is recommended for further trials for patients with metastatic renal cell carcinoma. Screening for the presence of 3 biomarkers appears to be a valid method for the early detection of malignant kidney cancer. This, according to data published in Cancer Epidemiology, Biomarkers and Prevention, a journal of the American Association for Cancer Research. Finally, if you live in the USA, you may be able to contribute $10 to support kidney cancer research, education, and advocacy from your mobile device when you text KIDNEY to 80100. For the complete details on these and other stories, visit the press room section at kidneycancer.org.